It's the PainExam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the PainExam newsletter at PainExam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the PainExam app with a premium subscription, or access for free with a CME subscription at PainExam.com. And now, without further ado, here's your host, Dr. Rosenblum.
So it's been a really busy month, and I want to thank you for joining us. If you're on my social media, you're well aware that I've been lecturing in Mexico on PRP ultrasound, and I was at the AMETD, which is basically a Mexican Association for Pain and Palliative Care. It's a branch or a chapter of the IASP, and that's the International Association for the Study of Pain. They invited me to teach ultrasound and talk about ultrasound guidance for PRP, as well as teach a demonstration of knee scanning, which I'll try to publish later this month. In the meantime, this is the audio from my YouTube video, which demonstrates my slides and lecture on how to safely use ultrasound in the office to guide accurate PRP shots, as well as some of the evidence behind it. In addition, my good friend Sudhir Dewan is really integral part of the New York, New Jersey Pain Symposium in November, as well as the Latin American Pain Society, which is an up-and-coming society that is really doing a great job of unifying Latin America. As the son of a Cuban refugee, this is something that is quite important to me, and I hope to get more involved. And anyway, I hope you enjoy this podcast, and I hope to see you guys at my upcoming course. I have a 2-day course, September 28th and the 29th, Regenerative Medicine and Ultrasound-Guided Pain in New York, and many other courses coming up, monthly ultrasound courses as well. So I hope to see you guys. Please shoot me an email if you have any questions, and don't forget to go to PainExam.com or nrapacademy.org for pain management board prep, and check out our app. Now, without further ado, here's my lecture from Mexican Pain and Palliative Care Conference in Mexico City, August 2024. Okay, so we're going to discuss using ultrasound in the office to do PRP injections. I'm going to start with the carpal tunnel, which there was a randomized controlled trial, and basically when they compared the PRP to steroid, they found that the PRP was overall better with respect to pain, as well as the electrodiagnostic functioning. And just to give you the ultrasound view here, you have the median nerve proximal to the carpal tunnel, which is usually where I access the nerve when I do a shot. I think it's a little less traumatic to the nerve because you have more space to work with. I've done some PRP for this. To be honest, it's not one of my go-tos. I don't really personally have as much success as they had in the studies, but I probably will be doing a lot more of it. And just in case you're not aware, I threw this little add-on to the slide. There was a recent publication, multi-society publication, ASRA, as well as a few other societies got together, and they now recommend not using steroids for carpal tunnel injections, just local anesthetic, as well as a number of other injections, such as a pudendal nerve block. Anyway, scanning the median nerve, you can get the cross-section, and this slide's to demonstrate my technique of hydrodissection. There's not much room for your needle. So if you inject on your way, you're creating a space for yourself in which you can inject below and above the nerve. I'm using a 25 gauge needle. You could use smaller if you want. Here's the longitudinal view of the median nerve as it travels into the carpal tunnel. And you can see the tendons underneath it, and you can identify them by wiggling your fingers. The tendons are hyperechoic, so they're usually wider. And here's the cross-section view following the median nerve up into the mid-forearm as it gets deeper in the arm. The shoulder is another popular target for PRP. We're injecting the glenohumeral joint, the subacromial space, the tendons, and the And the supraspinatus tendon is probably one of the most commonly injected tendons. So the PRP not only inhibits inflammatory effects of interleukin 1b, but it also increased the concentration of TGF-beta, which is enhancing the rotator cuff strength. But there's still controversy in some of the studies. And some of the controversy also exists because there are different PRP formulations. Not everyone is using the same PRP. I've seen people just take a test tube and spin it out once and inject that, which it could be PRP, but it may only have 3 times the amount of platelets as opposed to 6, 7, or 8 times as much. Here's another small study. Unfortunately, a lot of these studies are small, in which they injected the rotator cuff and they looked at 8 weeks out, which is not very long, and they found good results. Here's 200 patients in which they compared PRP versus sodium hyaluronic acid, as well as the combination of both, and that they found that the combination gave better results, so the hyaluronic acid with the PRP. So scanning the shoulder, this is the anterior view. You can see the coracoid process. The joint space is demarcated by this, the star, but the cartilage begins outside, right? You have the black space is actually not fluid. It's the hyaline cartilage. Here's the posterior view. And you could access this in plane or out of plane. You may ask the patient to adduct their arm to create more space for your needle so that you could come in plane. This is a biceps tendon injection, and you could see fluid, which is black around the biceps tendon. That's from prior to the injection. This is a tendinitis, basically. And I'll typically have a view like this and come in from lateral. This is the long head of the biceps. Here is a scan of the biceps muscle, and as you scan up the arm, you see the intertendinous fibers coalescing to form the extramuscular tendon. And it lies in the bicipital groove of the humerus. Okay, this is the subscapularis tendon, which can be exposed with external rotation. Here is the supraspinatus tendon. Kind of looks like a bird's beak. And the ultrasound is positioned like this. Here we're doing a cross-section of that tendon, and you can also see biceps tendons on the side. You have the patient put their hand in their back pocket to expose the head of the humerus. These are quite common targets for PRP injections. And here's the supraspinatus moving nicely under the acromion with abduction. Sometimes when patients have a rotator cuff tear, it will not look as clean. It could even have discontinuity. It's hard to see the thin black line above the tendon, which is the subacromial bursa. Here we're just scanning the, Okay, this is the infraspinatus tendon. So you can see with the external rotation of the arm, you can see the joint, the muscle, and then the tendon fibers are over there. What do they do? Okay. Now we're scanning to the side of the muscle, and the tendon fibers come to rest of the infraspinatus onto the humerus. A less common target. Teres minor. I'm going backwards. Okay. Okay, here was a subacromial bursa study, and basically they concluded that the PRP actually had earlier better results, which is the opposite of most studies I read on PRP. It's usually the long-term effect compared to steroid is better. But this is level 2 evidence. Generally the theme with PRP is it takes longer to work but lasts longer, and I'm seeing that in most studies, but not everyone. Decurvain's tenosynovitis, it's inflammation of the abductor pollicis longus, extensor pollicis brevis, and basically the band is there to prevent your tendons from popping off the bone when you do maneuvers like this. So you could do a diagnostic test by just having the patient flex in an ulnar direction while you're flexing the thumb and looking for pain. Here is the tendon. And the differential is Wartenberg syndrome, which is a radial neuropathy. Here's cross-section view of the two tendons. Just be careful, the radial nerve is close to the artery, so you don't want to hit that when you come in. Here they did a study of 40 hands, and they concluded that the PRP was an effective treatment for decurvainous tenosynovitis compared to steroid. Epicondylitis, which I know the previous lecture mentioned, it's not an epicondylitis, it's a tendinopathy, right? It's the extensor tendons, and the tendon gets inflamed or damaged, and PRP can help repair that. It's usually the extensor carpi radialis brevis tendon, which is right there. And here they concluded that the PRP was superior to steroids at 6 months follow-up. The medial epicondyle looks very similar to the lateral epicondyle. Basically, it's a very superficial bone. Sometimes you need to move your probe away and just do it blind if there's not enough room, or go out of plane, or you could come in with a very shallow angle behind the probe and get your needle between the probe and the epicondyle, but it's a very superficial injection. I've probably never put PRP on the triceps tendon, but why not, right? If somebody has a damaged tendon of the tricep, I'm sure you could try it. I probably would try it first before steroids. Here's the olecranon bursa, which you could barely see. It's right above the bone. Trigger finger, common problem. See it in my office quite a bit. There is evidence for PRP as well as amniotic fluid injections. Here we have the two tendons, the digitorum superficialis and the flexor digitorum profundus, right underneath it. And here's an injection. It's a little hard to see the needle, but it's coming in from the left. And we're just getting the needle into the tendon space. It's right there. It could be a painful shot. So I recommend a very small gauge, which makes it hard to see the needle. And I like doing it in plane, because if I have an ultrasound, I want to see the needle. You could do it out of plane, but then it's almost like a blind shot. Okay, so does anyone here mix local anesthetics for PRP? Okay, I don't. However, I was watching some videos on YouTube, and a couple guys actually are doing it. I don't want anything to interfere with my PRP. I'm even very reluctant to mix contrast with PRP, which is probably less harmful. The local anesthetic does limit the platelet's ability to aggregate and function. This study shows that there was not much of a change with growth factor release. However, I still don't mix local anesthetic with my PRP. What I do is, if I need to, I'll do a nerve block proximal. The AC joint, the acromioclavicular joint, beautiful joint to see under ultrasound, but once again, it's sometimes hard to get your needle in plane for this shot. If you really want to go in plane, I would suggest turning the probe this way and coming from above. And you scan lateral to find the joint space, which is a little tricky, but doable. Okay, oh, sorry. Controversy. Or maybe, well, it was a large meta-analysis basically showing that it doesn't work. Clinically, I've seen the opposite. I've seen amazing results. People who failed the Achilles tendon injection, steroid injection, suffered for a long time, within a few months, cured. So I don't know what the people who do their research on this particular body part, what mixture they're using of PRP, what their technique is. But basically, according to some of the meta-analyses and studies I looked up, they say it doesn't work. That being said, I still think it's ethical and safe to try PRP before a steroid shot to the Achilles tendon. So this is more of the pathological evidence that it works. This is not clinical evidence in this study. And so they're questioning the widespread use. Does anyone here do PRP for the Achilles tendon? Yeah. Okay, so rich or poor? Well, this study says it actually works, but there's no difference, whether you use leukocyte-rich or leukocyte-poor PRP. This is a really nice procedure, the plantar fascia injection. Once again, this is a procedure where I've cured the problem in patients who failed steroids, failed orthotics, failed everything and suffered for a long time. The fascia is basically above the fat pad. So this is caudate, this is cephalad. It's opposite, right? Because we're scanning from downwards up. And basically, when I do this one, because it's kind of painful and then they have to walk on it, I'll do a tibial nerve block. And it works pretty well. Even 3 mLs of 0.25% bupivacaine on the tibial nerve can last a day. Not the 2 to 6 hours you usually see with other nerve blocks. For some reason, when you get to the popliteal fossa and beyond, these nerve blocks tend to last longer than the textbooks say. Okay, so here's another study supporting the use of PRP, saying it's better than steroid for the plantar fascia, which I'm not surprised about. Level 2 evidence. Another study, there's a randomized controlled trial, 90 patients. And another study, 60 heals. And at 12 months, patients were improved, and this was statistically significant. Wrapping up with the hip joint, you see the X-ray image here. You see the femoral head and the neck under ultrasound. You need to just put your needle somewhere into the capsule. You're not basically aiming for that, right? We're not aiming for that. This is a ball and socket joint. We're aiming for this. Okay, I'm just doing a steroid injection here, just showing you the technique. I use a 25 gauge, 3.5-inch spinal needle. I find it's less painful. It's actually a sharp needle, but I've, thank God, never seen any nerve issues by using this needle. It's not meant to be very echogenic. It's not one of those special anesthesia nerve block needles. It's just a very cheap, basic needle, which gets the job done. So in terms of the hip, they injected hyaluronic acid and PRP. They found in this study, this group of studies, the PRP was not superior to the hyaluronic acid. Here they're just demonstrating that ultrasound-guided PRP shots can be effective for the treatment of osteoarthritis. In this one, they did compare the PRP and hyaluronic acid, and they found that the patients with the PRP had lower pain scores. Greater trochanter pain. Here is the gluteus medius tendon inserting on the bone. Here's just the bone itself versus overlying. It's usually a tendinitis, not so much a bursitis. We call it bursitis, but really it's the tendons that are typically inflamed, and that can lead to the bursitis. The knee quickly, patella tendon, infrapatellar tendon. You have the patella on the left, the fat pad here, the tibia. You can inject suprapatellar. This is a cross section. This is your target. This is the sagittal view, okay, with your probe positioned as such. Okay. Last slide, I think. Lateral collateral ligament, lateral meniscus, which is a little hard to see here. Iliotibial band, which is on top. And lastly, they compared placebo, steroids, hyaluronic acid, and PRP for knee arthritis. Who do you think won? PRP. Thank you.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.